or Ebola virus disease cases in Parlican, a remote village in Grand Cru County, as shown in the circled area on this map. So with a population of about 2,000 residents and near a subsistence gold mining camp, the village lacks cellular coverage, and the closest healthcare facility is 3 hours drive. While only 455 miles from Monrovia, given muddied road conditions, the journey to the village would take about 2 days. The partners had one more piece of information to share. The local county health team had been conducting Ebola surveillance in the region for several weeks, but the day before they called you, the surveillance teams had fled the village by foot after the residents threatened them with violence and seized their vehicles. Your team lead then ends the phone conversation and is eager to have boots on the ground to investigate the outbreak. He turns to you, his newly minted EIS officer, and asks if you're ready to go. What do you do? So we're going to come back to what we did and what I did in that circumstance. But first, let's review some of the details of the Ebola response in West Africa. So we know that the first Ebola virus species was discovered in 1976 in Zaire, now Democratic Republic of Congo, along the Ebola River, as shown in the map on the right. At that time, there were about 318 cases, with a case fatality rate of 88%. Since discovery, we also know that Ebola viruses have been found in several other African countries, usually in sporadic outbreaks, with death rates in the previous over 20 outbreaks ranging from 50 to 90%. As a viral hemorrhagic fever pathogen, Ebola virus belongs to the Filoviridae family of zoonotic RNA viruses, named after their long, thread-like appearance, as shown in this electron microscopy image. Of the 5 species of Ebola virus, human infection has been known to be caused by 4. The 2014 Ebola outbreak was caused by Zaire Ebola virus. This timeline shows the phases of the 2014 Ebola outbreak in West Africa. The reported number of Ebola cases per week on the y-axis, over the span of about 16 months on the x-axis, for each of the 3 color-coded, heavily affected countries, Guinea, Liberia, and Sierra Leone. And we'll see this map over and over again. So the outbreak is thought to have originated with the death of suspected patient 0, a 2-year-old boy in Guinea, in December 2013. So initially it was thought to be a cholera outbreak, but the first laboratory-confirmed Ebola case was tested on March 23, 2014 in Guinea. As a zoonotic disease, some evidence suggests fruit bats are the likely reservoir for Ebola. Transmission to humans is thought to occur from spillover events or human contact with infected wild animals, such as fruit bats or monkeys, followed by subsequent human-to-human transmission chains through direct contact with infected blood or bodily fluids. Cases spread along travel routes to eventually reach urban, heavily populated regions along the coast in Monrovia, Freetown, and Conakry. The 2014 Ebola outbreak has been the largest and most complex Ebola outbreak in history and the largest outbreak response in CDC's history. On August 8, 2014, the World Health Organization declared the Ebola outbreak a public health emergency of international concern, underscoring the need for a coordinated international response to contain the spread of Ebola. The outbreak would become an epidemic, with cases reported from 10 countries, over 27,000 suspected, confirmed, or probable cases, and over 11,000 deaths. In response to the outbreak, in July 2014, CDC activated the Emergency Operations Center, or EOC, to a level 1 activation, the highest possible alert, mandating center-wide involvement to coordinate technical assistance and control activities with partners. Over the past year, CDC has sent over 1,000 staff to Guinea, Liberia, and Sierra Leone, many of whom have been EIS officers, and many of whom have gone on multiple deployments. As well as there are thousands of responders at headquarters who worked on the domestic response, as well as coordinated the activities internationally. So let's now return specifically to the Ebola response in Liberia and identify some of the key challenges faced in halting EVD transmission. The Republic of Liberia was the first democratic republic in Africa, founded in 1821 as a resettlement country for freed African-American slaves, and with strong historical ties to the United States, as seen even in the country's flag. Liberia is home to over 4 million people, encompassing an area, I remember that sound, slightly larger than Tennessee, and is a low-income country with largely agricultural economy and infrastructure heavily weakened by an over 10-year civil war, which ended in 2003. One outbreak challenge in Liberia was poor border control. Porous borders with neighboring countries and high population mobility by multiple routes, such as motorcycles, boats, and cars, enabled easy migration and EVD transmission. The overburdened public health and health systems cannot be stressed enough. In trying to battle and stop the outbreak, in many instances, healthcare workers were unpaid. There were insufficient medical supplies and equipment. For example, in this picture, a non-functional ambulance at the main general hospital. Per the WHO, at the start of the epidemic, Liberia had about 130 doctors for 4 million people. There are 16 indigenous ethnic groups, and English is the official language, with a population literacy rate of about 20%. This underscores the need for health education in the community, and lack of knowledge and acceptance of Ebola, as we all know, was one of the fundamental challenges in the outbreak. Despite Ebola messaging in local vernacular, in some communities, local cultural practices and beliefs related to Ebola presented strong challenges to controlling the outbreak. Another outbreak challenge was inefficient use of the many stakeholders who descended on the country. With inadequate data management and at times poor coordination among partners, compounded by political pressure to underreport and intense media scrutiny. Poor transportation and communication infrastructure were especially challenging in remote regions of the country, like southeastern Liberia, where road access from muddied roads during the rainy season made case finding and contact tracing difficult. So with these challenges in mind, particularly those of remote areas, let's now return to what happened in the outbreak investigation in that remote village. So the goals of our outbreak investigation and of outbreak investigations in general were to identify isolate cases, assess transmission chains, and implement prevention and control measures. So what actually happened? So 1 week after that initial alert was received, we basically waited. We waited, one, because we needed situation awareness, and we were scared to go into a community where there was threats of violence and machete use. And we also waited as the county health team reconciled and re-engaged with village leaders. So after there had been reconciliation, our team left Monrovia for Grand Cru. Our team included, as shown in this picture, about 4 persons: myself, functioning as a makeshift epidemiologist, a communications specialist from CDC, and 2 Liberian Peace Corps staff who were our local guides. And a note about the Peace Corps had been shut down during the time of the outbreak, and to really help to resume Peace Corps activities, Peace Corps workers were volunteering as drivers and as local guides with the CDC. So what did we actually do? Our team spent the next 3 weeks working with the county health team and Ministry of Health in investigating the outbreak. So while in the field, the majority of time was actually spent in meetings, so in planning meetings, as well as in strategizing the response activities. So it took us about 2 days to get from Monrovia to southeast Liberia. After several days then of planning and meetings with the county health team, we were also in daily communication with CDC staff at headquarters in Monrovia. So you can't see the breakdown of time here, but I'll describe it. So in the red circle, in the red pie of the circle, was data management. Data management was tedious, and it wasn't what I had imagined spending most of my time doing when I deployed, sorting through handwritten narrative surveillance reports and reconciling line lists in Excel spreadsheets. So it was tedious, but vitally important. Case report forms were incomplete, or cases were often confused with contacts. Only by reconciling this data entry could we prepare for continued case finding and contact tracing on the ground. The green portion of this pie then was spent in travel, which was about almost 30% of our time in transit. And then the smaller gray portion was the time spent in actual case finding and contact tracing. So when we finally arrived in Parlican, the village elders had a town hall style meeting to announce our arrival, clarify our mission to the community, and express their cooperation. We were told that there were no longer wet cases in the village. All symptomatic patients had either died or fled to nearby villages. We were told help had come too late. Accompanied by the village elder, we then went door to door to households in the village. At the entrance of each household, trying to maintain a careful 3 feet or more distance while interviewing, we spoke with the heads of household using a local translator, asked about any EVD-related illnesses or exposures. For anyone meeting the EVD case definition, which we'll review in a minute, a detailed viral hemorrhagic fever, or VHF, case report form was completed, and we then compiled a line-by-line list of demographic information for any of their contacts. These cases and contacts were later reconciled with listings previously collected by the county health team. We use the following case definitions. An EVD suspect case was defined as someone who had both consistent symptoms, whether elevated body temperature or fever, and other symptoms as shown in the box to the right, and epidemiologic risk factors, such as funeral attendance or touching bodies, within 21 days prior to symptom onset. A probable case met that definition and had a known EVD exposure. A confirmed case was a case with laboratory-confirmed evidence of Ebola virus. So, this is going to be a busy flow chart, but it'll be very quick what our take-home points are. So as shown in this flow chart, which is the ideal surveillance flow pattern, case finding and contact tracing are the first elements of EVD surveillance in any outbreak, which is circled here. So an alert is made, a county surveillance officer then assesses whether the patient is sick or not sick, and from there decides to complete a case report form and collect a list of contacts. After symptomatic cases are found, they're held in a holding center for laboratory testing. If found to be EVD positive, they're sent to an Ebola treatment center. If found to be negative, they're then discharged into the community. All contacts of confirmed cases undergo active monitoring for 21 days from their last exposure. So again, that's the ideal. We'll get back to that. As we went door to door, members of the county health team also took that as an opportunity to follow up on contacts that they had previously identified. So contacts were to be monitored with daily temperature readings and assessment of any symptoms. This was supposed to happen every day for 21 days. In practicality, it was difficult for the county health team, whose office was based over 3 hours away from the village, to have monitoring on a daily basis. This issue would later lead to training and use of local-level community health staff, so local-level people who would serve as contact tracers because they knew the communities and they knew how to reach people in their communities. So for contact tracing, over the next week of that time we were in Parlican, we also traveled with the county health team to the gold mining camp, and nearby villages accessible only by foot or motorcycle, where several of the contacts were said to have fled. It was much like a Finding Waldo, looking for people who had intentionally left their communities because of stigma. All the contacts we found ended up being well-appearing, although some were still within their 21-day incubation period. So we're back to the flow chart. So far it seems as though we've been following this model for case investigation. So the only problem that we thought of before we got to the village and while we were in the village was, what do we do if we actually find wet cases? There were no holding centers within 3 hours of the village and no Ebola treatment centers in the entire southeast region, much less in our Grand Cru County. Even if the county health officials were willing to accept sick patients at their offices, there were no functional ambulances to safely isolate and transport them, and many of the county health officials were scared to go into the village and provide that kind of care. Laboratory specimens had to be taken several days' journey by motorbike to Monrovia. Again, this is because of the road conditions. And there were no funds for fuel or paying these drivers to transport these specimens. In short, we were missing the essential elements needed for prevention and control. So just to summarize some of the findings during that investigation, we identified a total of about 36 EVD cases, of which 17 or 47% were laboratory confirmed. All of the symptomatic cases, as the village elders had told us on arrival, were reported to be either deceased, the case fatality rate was 82%, or recovered from their symptoms after being isolated and cared for by their own family members. There were no wet cases as well because of the time delay from when this outbreak started, which we'll review in the next timeline, to when interventions were brought. Of the contacts with known whereabouts, 35 were identified for continued follow-up. Village residents reported using PPE that they had confiscated from the Ministry of Health vehicles to perform safe burials of some of their dead. They claimed that the stigmatization around their community is what had led them to chase out the county health team, who they felt were not there to meet their primary health needs. From the narrative histories obtained from village residents, we pieced together the following summary of events. We think that the first EVD case in Parlican was on August 4th. We learned she was a 41-year-old woman who returned to the village from Monrovia to seek care of a traditional healer after she became ill with fever, vomiting, and body aches. She was also cared for by her older sister and stayed in her older sister's home. A few weeks later, both she and her older sister and the traditional healer who they had sought became sick with similar symptoms, followed by several members of the traditional healer's family. The index case continued to worsen, and she eventually died on August 21st, at that point having moved to a neighboring county. On September 6th, her sister also died and became the first suspected EVD death in Parlican, followed by the traditional healer. Over the next 2 months, 19 close contacts of either the index case or her sister developed EVD-like symptoms, of which 9 died. The last probable EVD death in the village occurred on October 11th, a 12-year-old boy with mucosal bleeding. Now, in this timeline, there are lots of cases that we don't see. There were cases that were identified retrospectively, of which we're still not sure what the transmission chain and link was. So the Parlican story was just one example of an Ebola outbreak in a remote community. As Ebola spread from urbanized populations in the capital, many hotspots would be seen in remote regions of the country, and many sharing similar challenges of their remoteness. The CDC response team and Ministry of Health published a report of 12 such outbreaks in remote areas of Liberia. The MMWR detailed both before and after implementation of a revised rapid response strategy. As shown in this map, so if we're between July and November then of 2014, there were 12 outbreaks identified by blue dots in remote areas that resulted in a large number of cases. There were a total of 236 EVD cases in these 12 outbreaks, with 158 laboratory confirmed. So again, after the Parlican outbreak, and from experiences from these early outbreaks, the CDC Liberia response team, in coordination with many partners, developed the RIGHT strategy, or Rapid Isolation and Treatment of Ebola strategy, to coordinate response partner efforts in rapidly mobilizing resources and healthcare to reach hard-to-reach places. A lot of the interventions then that were planned seemed kind of obvious to us if we think about them now. If a place is difficult to reach, set up a mobile clinic in that community. Use helicopters for specimen transport and for ready drop of supplies. So with these renewed response efforts and with this coordinated plan, the proportion of patients isolated and treated increased and the case fatality rate decreased. I'm sure there were many other factors involved in both of those changes, but we'd like to claim credit for part of it. So as shown in this chart, showing the 12 outbreaks over time, and in this case, Parlican is circled. For each, there's a period from the number of days from the first case alert, which is the blue line, to the last case, which is the blue diamond. And then the duration of the outbreak is shown in the gray bar. Over time, and with implementation of multiple strategies, including the RIGHT strategy, the interval from alert to last case we see decreases. So some other interventions then that came about from evaluating these 12 outbreaks. So in addition to rapid mobilization of resources, the RIGHT strategy highlighted the following interventions, which were proven to be effective in these outbreaks. And again, many of these findings seem obvious of what you would do, but actually doing them is what required a lot of coordination. So engagement of traditional and community leaders, community education, active case finding, contact tracing and monitoring, quarantine of any high-risk patients, isolation and treatment of patients, and ensuring and safe burials. So what were some of the lessons that I personally learned while in Liberia? First, without chains of transmission, there is no outbreak. That's the number one lesson I learned, the importance of rapid case isolation and contact monitoring. Stopping chains of transmission always stops outbreaks. Not touching is hard. So during my deployment, I never hugged anyone, not cute toddlers or my EIS classmates, or even friendly Liberian grandmothers who thought I was Liberian. It was hard, especially when you felt emotionally drained. While we knew, and again, the policy on shaking hands and touching changed during the course of the response, and at that time we knew why the policy was in place, it was still hard to make warm connections without close contact. Playing well together always counts, but first, and this is something I'll take from my pediatric training, fever is sometimes not your friend. So I've never been so fixated with body temperature than during my month in Liberia. At every road checkpoint, we had our temperatures taken, often with wildly inaccurate readings. I was 45 degrees for several days. The one time I was actually febrile during my deployment, and the 21 days of twice daily temperature monitoring when I returned to the States, all made me keenly aware and perhaps irrationally afraid of what it would mean to have a fever. Playing well together always counts, and this again goes back to the idea of coordination among all of the stakeholders. So I think in my first week in the hotel in Monrovia, I met over 20 different international partners from different organizations. With so many partners there to help, it's easy to duplicate or frustrate each other's work or just get on each other's nerves. And we sometimes forget that we're there to assist the Liberian Ministry of Health and in-country partners rather than follow our own objectives. Finally, there's ongoing need for in-country capacity building in all of the affected regions and, as I saw, in Liberia. So let's now turn briefly to summarize CDC Ebola response activities in unaffected countries. So in October 2014, WHO created an action plan for increasing Ebola preparedness in unaffected countries at high risk of an EVD importation. This plan focused on providing technical assistance to build in-country capacity in core areas as listed. For example, infection control, contact tracing, case management, surveillance, lab capacity, and community engagement. High-risk countries were defined as those with weak healthcare systems and that shared land borders or strong trade links with the 3 heavily affected countries. In total, as shown in orange on this map, 17 countries were classified as high risk. To support the WHO in this preparedness plan, CDC deployed over 128 staff to 14 high-risk countries, with the mission to provide training, guidelines, and protocols to assess and aid each country in their Ebola preparedness. In January 2015, I deployed to Ghana on the high-risk unaffected countries team. Slightly smaller than the state of Oregon, Ghana is home to over 26 million people. Ghana is also my home, where I was born and where my parents grew up. So it was humbling to be able to mobilize preparedness in my native country. During my 6 weeks in country, I worked with the WHO Ghana country office and was really their functional SCUT intern, available for any task they assigned to me and serving as CDC's eyes and ears in country. So of note, compared to our 20-plus team of responders in affected countries, in unaffected countries, CDC deployed 1 staff person to each country at a time. So for 6 weeks, I was my own team leader, but of a team of 1. I spent the bulk of my time attending Ministry of Health Ebola Task Force meetings, where I represented CDC, and doing data entry. This is a common theme during this experience, data entry. So the Ministry of Health had gathered over 70 VHF case report forms from across the country of suspected EVD cases. So there were no confirmed cases in Ghana. All of these cases ended up being test negative if a test was done. But for complete surveillance and for planning, accurate documentation was still needed. So a few personal take-home lessons from my time in Ghana. One lesson I learned was that it's sometimes harder to keep momentum going in preparedness than in crisis. During much of our planning meetings, there was already a sense of Ebola preparedness fatigue and waning fears of an actual importation happening. Ebola was also not the only disease or even the only pressing disease facing the Ministry of Health. Now again, this seems obvious, but when I arrived in country, there was a cholera outbreak in the capital of Accra. So again, this may seem obvious, but it's sometimes easy to be insensitive to this reality when pressuring colleagues to finish Ebola preparedness tasks ahead of their other responsibilities. In the WHO county office, I was one of the few people whose only job was Ebola preparedness. Finally, I had to learn, and I had to learn this over and over again, that things would get done, but at a different pace, and that that was okay. And more than leading the planning efforts, or even collecting data, my role was to be flexible and available to help the WHO staff in their preparedness activities. Let's conclude by reviewing the current status of the Ebola outbreak. So as of January, and as of January 15th, there have been 28,637 total Ebola cases. So in this image, we see cases in light blue and deaths in dark blue. In total, there have been 11,315 deaths, and we can see the breakdown by country here, with the most number of reported cases in Sierra Leone, but slightly higher numbers of deaths in Liberia. We know that tremendous efforts were made in the domestic Ebola response, with our own Children's National spotlighted as one of the few pediatric Ebola treatment centers in the country. In the U.S. response, in total, 4 patients were diagnosed with Ebola in the U.S., and 11 were treated for Ebola. So just briefly to summarize these cases. So Ebola was diagnosed in 4 persons, 1, an index patient who traveled to Dallas, Texas from Liberia, and unfortunately succumbed to Ebola, 2 healthcare workers who cared for the index patient, and 1 medical aid worker who traveled to New York City from Guinea. So again, these are persons diagnosed in the United States. But in terms of overall treatment of persons, 6 healthcare workers and 1 journalist have been infected with Ebola virus while in West Africa and were transported to hospitals in the U.S. for treatment. Of these, 1 of the healthcare workers died after being transported from Sierra Leone and being cared for at Nebraska Medical Center. So how do we get to 0, and are we there yet? A national Ebola outbreak is considered to be over after double the 21-day incubation period, or 42 days, from the last patient in isolation who tests negative for the virus. Liberia was the first heavily affected country to be declared Ebola-free on May 9, 2015. Since then, small clusters of cases appeared after that declaration, but were effectively detected and transmission chains halted due to enhanced and continued surveillance. September 3, 2015, for the second time, Liberia was declared Ebola-free, and again there was a response to clusters of outbreak. On January 14th, Liberia was declared Ebola-free for the 3rd time and continues in enhanced active surveillance. Sierra Leone was declared Ebola-free on November 7th, 2015. Recently, on January 14th, a new confirmed case was detected from a deceased woman who died in her home and received an unsafe burial. The origin of the transmission is still under investigation. Guinea was declared Ebola-free on December 29, 2015, and continues in a 90-day period of enhanced surveillance. So, in summary, we're in control and in the vigilance phase of the outbreak. From May 2015 to January 2016, all of the heavily affected countries have at least at one time been declared Ebola-free. So, in conclusion, the 2014 outbreak was the largest Ebola outbreak we've seen, and control was achieved domestically and internationally through coordinated response. There continues to be ongoing need for public health action in disease surveillance and in control in the region. And as part of this, we know, many monies going toward global health security and toward developing sustained public health systems within each country. I'd like to thank the staff who contributed to the presentation. I'd like to thank all of you for your attention and invitation to present. Open for questions.
We have plenty of time for questions, so Dr. Teach has the microphone.
On behalf of all of us, thank you. This is just unbelievable work, and we all owe you an enormous debt of gratitude, you and all your colleagues. So thank you very, very much. And in the form of a follow-up question, have there been any modeling of what ifs? What if the CDC and the EIS and all the international partners who were involved hadn't come to assist the critical local public health authorities? What might have happened in the context of this epidemic?
So there has been modeling. I'm not sure if there's been modeling of what would have happened in the absence of all of the response teams, but there's been modeling of what would happen if the outbreak continued, even with those response efforts ineffective. And there were many reports, some of which were overblown in the media, showing what would happen in that circumstance. I don't have exact numbers for you, but there's whole modeling teams who were involved in that forecasting.
I wanted to echo what Dr. Teach said. That was a wonderful lecture, and thank you for putting your health and your life on the line for all of us, as well as for the people in Africa. My question is that Ebola has existed since the mid-'70s. Why did this much larger outbreak than ever before occur, and what does this tell us about the future?
So that's a very important question, and I think I have two answers for that. So the first question of why, I think we still don't exactly know why was there such wide transmission. The second part of that, though, is that we have some hypotheses as to why. So one idea was that particularly in these urban regions who were unfamiliar with Ebola as compared to other regions in the country, just the rapidness of transmission and the absence of any control measures sparked large chains. Why that happened now versus previously, or if there's anything different about the Ebola viruses now as opposed to previously, we're still not sure. It doesn't appear as though there's been some rapid mutation in the Ebola virus. Yes, sir.
Very impressive, and I commend you. One of the big issues that I wonder about is communication. A, what's the literacy of the population? And B, how many people from all these different organizations and countries, is there a common language that everybody could use, or did you have to have translators to get you back and forth? But I think just that aspect of it alone is amazing that you all could accomplish what you did.
And even if we look at that aspect just in Liberia, where there is the common and official language of English, even among English speakers, there's variations in vernacular and understanding. So we continually needed translators. And the population literacy in Liberia, which I think was similar in Sierra Leone and Guinea, was around 20 to 30%.
Quick question. So you mentioned how now in Sierra Leone there's still heightened surveying and to check for ongoing outbreaks and things like that. What's the funding issues? How long can they have that kind of heightened surveillance? And also, at what point do we start wondering if there's a new outbreak that's not this Ebola outbreak and not something else that's come up?
So fortunately, there's continued, and it appears to be there will be sustained funding. So, for example, there's a global health security initiative, which involves CDC and multiple other donors, that will be in place for 5 years in all of the affected countries and in the high-risk countries. So I think there will definitely be continued funding for Ebola surveillance, and perhaps even more exciting to me, there's going to be funding for parallel platforms and surveillance of other infectious disease, riding on the models and resources used for Ebola. There was a second part to your question, which was, how do we know if there will be, if there's a different virus? So I think how we'll know is just as we improve and continue to have laboratory capacity in all regions from that laboratory testing, and if there's any difference perhaps in the clinical presentation, those will be our first clues to see if we're dealing with a different disease process.
Hi, Grace. True pleasure to see you. And really, really wonderful to see you, not just here back, but in action. Quick question to you. With obviously, we'll link it to HIV, and I will link it to HIV is another global epidemic that is chronic in nature, that's not going away in a foreseeable time frame. You've done a fantastic job doing a very difficult health system straightening in a remote areas. How is CDC approaching, and what is your personal view on using that network? You've put effort, you've created these liaisons, and we do know that ongoing health problems are there. There's frequent overlap between infections. We do know there is a new test and treat approach to HIV, for example, where WHO is going to recommend in the 2016 guidelines to treat everybody. So how can we use the work you've done beyond the epidemic to keep this network of the community outreach to be able to sustain other health needs of the population? Is any thought, any funding allocated in that direction? Because it would be pity to see that wonderful work you've done just be limited to one disease and one epidemic. Thank you very much again for coming.
Definitely. And with that, I'll echo again that funding from sources such as this Global Health Security Program, that's exactly what they're setting out to do, is the staff that have already been trained in surveillance and that are in the field, the resources for laboratory capacity, that they will be used in parallel for other disease platforms. So, for example, if I think about in Ghana, there was a CDC country office whose primary work was in PEPFAR and was in HIV/AIDS. Our activities, though, were very much disjointed, and they had very little interaction with us during the response. But that was because there wasn't seen to be a shared objective. But now with funding to unite both of those platforms, I think there'll be a lot more collaboration, and we'll see HIV/AIDS, malaria, cholera, a lot of overlap of care.
Thanks again for coming. I think this is a wonderful, wonderful kickoff to our Global Health Initiative, and the administration really backing a new, not a new program, but basically a program to help bring things together and really address global health needs in a cohesive way. And I think sharing your personal experience is one of the best parts of this, and I know that you've hopefully inspired lots of the residents and the students to become global health warriors and eventually leaders in the field. And so I would love to ask you in terms of recommendations, you know, you were on the ground 2 months after your fellowship. What would you recommend to medical students, residents, in terms of those who are kind of thinking about it to go forward to do exactly what you want to do, or to enter the field in terms of what they can do now or what potentially they can, other opportunities at the CDC that they can take advantage of?
And I think Kathy was planted so I could wax poetic about the EIS program. One way to do that would be through a program like EIS, where they recruit physicians, graduate-level scientists to go right into the field and to be mentored in those experiences. Similarly, and during this experience, I didn't provide any clinical care, and I missed that. There are other opportunities to be involved in clinical care in the Commission Corps, with MSF. There are many groups on the ground for training in actually providing patient care. Was that an answer to your question, or other opportunities to describe?
No, absolutely. I think that that's one of the things that attracts many people to global health, is that you get to do a combination of things in terms of your little pie is almost exactly what you end up doing, where you're, you know, doing a lot of clinical work. I mean, you're not doing a whole lot of clinical work, but you're doing a lot of data, a lot of meetings, a lot of sort of creating the systems strengthening. And so I think for our med students and our residents, in terms of education and being able to figure out, you know, what that looks like, I think is fantastic. So thank you for sharing.
And many of my co-EIS officers came straight out of residency, so there's no requirement to have fellowship before EIS.
Thanks for the very wonderful lecture. I'm wondering, are the veterinarians or anybody who deals with animals monitoring what's going on in the animals before the problem gets to the people?
Yes, they are. And so there were several veterinarians involved in the responses in all countries, but there's also teams focused on the animal-to-human interface and in monitoring that interaction, both in the Ebola response and then particularly in our influenza group. There are whole teams who that is their focus.
I want to first thank you as a representative of the CDC group that went to West Africa in general. As one of the countries that was affected, and the index case came from Liberia to Nigeria, the CDC intervention curtailed that to what could have been a potential disaster, because the index case came to Lagos and came to an affluent environment. One of my friends lost her life in protecting the community and in Nigeria, but as you see, only 8 people who were in contact died of the 20 who were exposed. So I echo the same response of thank you. Thank you so much for millions of people who you guys responded to, not just as you know, members going into the community, but also giving first line response and help to the community. My question to you is this: you reported, for instance, in the village you went to, 9 out of 19 died, and as I just said, 8 out of 20 in Nigeria, one of whom was one of the physicians who actually was in contact with that index case, who did not die. What exactly have we learned from the whole process that helps, or what kinds of protective mechanisms or immune responses have we learned that some people have and others don't? And in what ways do you think the CDC or other groups are going to help in that, in projecting that? Because we still have this, as you saw, the Zaire came to West Africa. Some of the barriers are in the types of language. The countries that were most affected are the English-speaking countries, except Ghana, of course. And I think that was because you were there. So some of that is the travel, the borderless societies that we have there, where people migrate. A lot of people left Liberia and actually went to Ghana to avoid contact with people in their villages or in their towns. So is there anything that we've learned that you know of that in immunology or in the immune system, or maybe Roberta can address that too?
So I know that there's still investigation going on in survivors to determine what, if any, characteristics of their disease process, their immune response, both leads to resolution of their symptoms, and then what, if any, complications they continue to have. But I think from what I know, so the big answer to that question in specific, I don't know. What I know in general is that simple intervention, particularly in communities, still work. So, for example, in the communities that we visited, what often determined survivors from non-survivors was the care that they were given. We were told about persons whose families deserted them versus persons whose families were able to find whether an outfit to use as a makeshift glove, something to use as gloves to protect themselves, gave them daily water and food and nutrition, and that supportive care, in many cases, helped them to survive. So it's kind of basic, providing that basic rehydration supportive care, but then using what you have, where you have it, to provide that care safely.
I was going to echo that you know, if you look at the case fatality rate in the countries where the patients actually got to critical care capability and ability to be hydrated and have, you know, all the interventions we have, the case fatality rate is lower. So I'm not aware of any immunologic data yet, but I think it's more just basic stuff. You know, can you actually intervene while they're in that period of really extreme volume loss and coagulopathy? Well, thank you so much, Grace. It was fantastic. I wish we had more time because she confided to me at dinner last night that really what they've been waiting for is the outbreak of the new pandemic flu strain, because you've heard about the turkeys they've had to kill, and so she's been directly involved in that as well. But maybe we'll have her come back for another talk. So thanks, Grace.
Thank you.